Okay, welcome everyone. Thank you all so much for joining us for our Metro Council webinar. I'm Jamie. I am with Metro Council. I'm also with University Health Behavioral Health. And a little bit about Metro Council. So we are the Metropolitan Council of Community Mental Health Centers. We represent 9 different entities that make up the public mental health system. So that includes University Health, Behavioral Health, Swope Health, uh, Beacon Mental Health, Rediscover Mental Health, Comprehensive Mental Health, Wyandotte Behavioral Network, Johnson County Mental Health Center, Center for Behavioral Medicine, as well as Mental Health America of the Heartland. So all those different 9 entities represent Metro Council. We have education opportunities, training opportunities, opportunities to collaborate. And so we have our free second and fourth webinar, second and fourth Thursday of the month webinar. And then we also have a very large mental health conference that we host every year. If you have not yet, please save the date. It'll be May 29th and 30th at Johnson County Community College. I am so excited for this conference. We have 2 national keynote speakers, Dr. Stephen Lloyd, who is the doctor that Dope Sick is made. Anybody's seen that show before? Dr. Stephen Lloyd is actually the doctor that Dope Sick was made, modeled after. And then we also have Dr. Ashley Smith as well, and she's going to be talking about unseen joy. And so excited to have both of those national keynote speakers. And then we also have 72 breakout sessions for you to choose from, along with contact hours. And so we are also really excited to say that while everything also has gone up in price, our conference has not. So it is still $50. And registration should be coming out in about the next week. So please save the date, May 29th and 30th. It'll be a phenomenal conference. We hope to see you there. So with that, I am so excited to introduce our webinar speaker for today. A couple things to note before I do though. We do use Zoom webinar. So what that means is you're able to see DJ, you're able to see myself, but you're not able to see yourself. So they'll be able to communicate through the Q&A along with the chat box. And at the end of our time together, you will get a certificate of attendance with 1 contact hour that's available at the end of the webinar. So a couple things just to note, the views and opinions presented are those of the speaker, don't necessarily represent the opinions of Metro Council, but I know DJ and I know he will do a phenomenal job. So with that, let me just do a little introduction for DJ. So DJ is the Public Health Analyst with the CDC Foundation supporting the Overdose Response Strategy in the state of Kansas. He has 8 years of public health expertise, specializing in data visualization and geospatial analysis. DJ is a recipient of the Esri Special Achievement in GIS Award for his work incorporating social determinants of health and equity data into overdose prevention activities. He holds a Bachelor of Arts in Political Science from Wichita State University and a Master of Arts in Global Security from Arizona State University. So with that, I am so excited to introduce DJ.
Yeah, thank you, Jamie. For those that don't know me, I work for the Overdose Response Strategy. First, let me just put this disclaimer up here that these views don't necessarily represent CDC Foundation, the U.S. government, or the CDC. They more represent what I do in the state of Kansas than they do the organization's positions. So the Overdose Response Strategy is a collaboration project between public health and public safety with the overall goal of reducing fatal and non-fatal overdoses. There's at least 2 of us in every state. There's 1 public health person like me, and then there's 1 law enforcement person. Missouri, I know there's people from Missouri on the call. So you also have two people. Their names are Brenda and Van. And if you want to connect with them, you can go to our website, orsprogram.org. Feel free to also email me. I'm happy to make introductions as well. There's some pieces in here you'll see a lot of the geospatial stuff. I'm really one of the only people in the program that knows how to do that kind of things, but I do lend support to other teams across the country when it comes to geospatial analysis. So always happy to help out if you have questions or if you'd like to have some level of geospatial data for your organization or for your planning, whatever may occur. I like to start off with a fun picture of Kansas. This is cows versus humans. This is quite a data-heavy presentation, so I kind of like to start it off with a joke. But what you're seeing there is cows outnumber us 3-1 in the state of Kansas, and Haskell County down in the Southwest has about 500,000 cows. And so, yeah, it's kind of my icebreaker for the day. We'll go into overdose fatalities. So I don't have any Missouri-specific data. I'm going to show some Kansas data, and then I'll show some of the projects that we're working on in the state of Kansas. Hopefully, those projects will still inspire people in the state of Missouri or give you an idea of what you can do. They're across the board. Like I said, I do lend my expertise in mapping and assistance to other teams across the country. So if you're interested in any of the things that show up, feel free to email me. So overdose fatalities have relatively followed what we've seen in the national trends, increasing all the way up to 2022 with a decline in 2023. State of Kansas, Missouri, very similar through kind of the proportion of what's an opioid fatality or related fatality compared to a psychostimulant related fatality. We've been seeing increase in cocaine related fatalities as well as cocaine related seizures, although that did decline in 2023 as well. As far as age group goes, most of the fatalities that we see are between the ages of 25 and 44. And also just a note that if a person was using multiple substances, the substances are counted each time. And so one individual may be represented 3 or 4 times in this chart, depending on what substances were detected at the time of death. And then we also following national trends, the exponential increase in the male overdose rate compared to female overdose rate from 2018 to 2022. And then a decline in fatal overdoses among every racial and ethnic background except the Black population. Black population did increase by 13 fatal overdoses in the state of Kansas. When we look at the data specific by drug type, the opioid-related fatalities among the Black population is about 2 times higher as a proportion of population than it is in the white population. Methamphetamine is slightly higher. It's not significantly higher, but with cocaine-related fatalities, the Black population experiences cocaine-related fatalities at a rate of about 10 times higher than the white population does. And I mention this because a lot of the messaging we see or a lot of the messaging we put forward, right, is around, could be one pill can kill, but generally the messaging is around opioids and counterfeit pills. But those things may not be culturally relevant to the Black population if cocaine fatalities are 10 times higher among that group than it is the white population. So it is probably a message that we need to start sending out or communicating and really start looking at how we can communicate what's happening with the cocaine supply or cocaine-related fatalities with our populations. For emergency department visits, we access Essence, as does the state of Missouri, I believe. What we see is a relatively high number of our overdoses are suicide attempts. Statewide, it's about 20% of our overdoses are suicide attempts. That is different for Shawnee County or Topeka, Kansas. It's almost 50% of the overdoses that come into the ED are suicide attempts, which is really high. There was a EMS report, a national EMS report from NEMSIS, probably about 3 or 4 months ago that showed that Shawnee County is actually in the top 10 in the country for overdose EMS calls that are suicide attempts. I also bring this up because I don't think we can separate mental health or suicide-related overdoses from the overdose conversation itself, but that's particularly true in Shawnee County. If you're in a county relative relatively like Topeka or Shawnee County, mental health should always be a part of the conversation or part of the trainings moving forward. For opioid or for emergency department visits, suspected overdose, you can kind of see South Central Kansas, where Reno County, Sedgwick County is, Wichita, Hutchinson, Kansas, but then also Wyandotte County in Kansas City, Kansas has a really high overdose ED visit per capita rate as well. When we look at it by gender and then by age group, you'll see that females between the ages of 15 and 19 are really off the chart. Now, for that population, it's over 50% of those are suicide related, majority of them being suicide attempts. So that's 708 ED visits in a 1-year time frame for females between 15 and 19. The bulk of that is females 15 to 18. What we relatively see is after 18 or after turning 18, the suicide rate starts to plummet. Part of what we track is the months that are most common for teenage girls specifically for overdose suicide attempts. And those months are September and then January into February. So it starts to decline a little bit into November, December when students are going on winter break. When they come back to school, it starts to increase again. And then it drops a ton once school's out. And so during the summer, the teenage girl suicide attempt rate is actually relatively low, and then it spikes again as they end up going back to school. So part of what I would like to see in Kansas is probably more messaging, more strategy based on that, because it is one of the most predictable statistics I have. It's every September we see a spike in overdose attempts from teenage girls, and they're all almost suicide related. And then we have no insurance. And so Wyandotte County in Kansas City, Kansas, 96% of the ED visits had no insurance listed for an overdose. And that's the highest, or one of the highest in the state of Kansas. Crawford County was actually the highest. And part of that may be fluctuated due to the student population. And a higher percentage of the ones in Crawford County are also suicide related compared to Wyandotte County.
Hey, DJ, we had a
Yep.
question. Is alcohol represented in at all when considering overdose deaths? Maybe not alcohol-related fatalities, but alcohol poisoning.
It's not in the fatality data that I showed you, and it's also not in this emergency department data that I'm showing you. So I'm pulling overdoses that do not include alcohol. And then when we go to EMS calls for a suspected overdose, we use overdose detection mapping application program, or ODMAP. We have statewide implementation in the state of Kansas. Missouri has, probably a couple of counties that are entering into ODMAP, and there's no statewide implementation. So our board of EMS dumps all their EMS call data into ODMAP, and then we have a couple of coroners in Kansas City and then in Reno County that enter the fatality data in manually. We don't have a centralized coroner database like Oklahoma does. Oklahoma has statewide implementation with their coroners. So they dump all their fatality data in. So what we see in the EMS calls from suspected overdose by primary substance, fentanyl specifically pulled out. A lot of times first responders don't enter the type of opioid, but they do say opioid, but a lot of those are likely fentanyl calls. So you can kind of see a good chunk of them are opioid related, but methamphetamine calls are also very common. And naloxone administration tells us probably when polysubstance was prevalent with methamphetamine toxicity at the time of the call. So you can see that the naloxone administration rates are actually relatively low with the methamphetamine suspected overdoses. Naloxone administration relatively high in Sedgwick County compared to the number of overdoses they have. It's kind of similar with Wyandotte County. You see quite a bit of naloxone administration there compared to the number of overdoses they have as well. And then when we look at the calls as a per capita rate, all overdose calls, it's Northeast Kansas, a little South Central, Southeast Kansas. But when we look at just the opioid overdose calls, it still stays primarily Northeast, South Central Kansas, but Southeast Kansas starts to dissipate a little bit. That's primarily due to we see a lot more methamphetamine calls in Southeast Kansas compared to opioid overdose calls in the Northeast and South Central Kansas regions. Here's kind of what a map looked like up till, I believe, yesterday. for the past year, so 10,466 suspected overdoses. Some of these could be duplicates. It's really hard in Kansas City, Kansas to pull out non-duplicates, but that's where most of my duplicated data comes from, is the Kansas City, Kansas area. And then part of what we do with this data is try to make sense of the location. So ODMAP allows you to pull a heat map of the density of overdoses. And then what I try to do is make sense of that data. Because I think a lot of times when we pull up a heat map of something, we assume it's the neighborhood. But what we found through analyzing the data is most of the time overdoses aren't on a specific home or a specific neighborhood. The bulk majority of them are happening at very specific facilities. So like the lodging facilities off Broadway and Wichita. And if the map extended out a little bit west, where there's a ton of lodging facilities in West Wichita as well, near the airport, where there's not a lot of residential. So a lot of the overdoses, fatal, non-fatal, on ODMAP that we see from the EMS calls are very correlated with the location of lodging facilities. We also see where our unhoused population is. A lot of the gas stations will tend to show up quite a bit more as well. So you'll see the gas stations on there in the downtown Wichita area. Some of the lower income housing or apartment complexes tend to show up. Correctional facilities, in some counties, they're the biggest hotspot in the county. This is particularly true with places like Butler County, El Dorado, Kansas. Most of the overdoses, or a good chunk of the overdoses, are happening in their jail or their prison. In Sedgwick County, a good chunk of them happen at the Sedgwick County Jail. We also see homeless shelters themselves as hotspots, and then residential treatment facilities tend to show up as hotspots as well. So part of what we do is make sense of this information, but then we can kind of act on it. So one of the projects that we worked on in Wichita was partnering with Wichita Police Department, because they had relationships with the lodging facilities. And we were able to put naloxone in every one of these lodging facilities that were in a hot spot. Instead of having to put them in all the lodging facilities, we were able to very directly and purposely place them in the lodging facilities that tended to have an overdose problem. And then we did the same with the apartment complex, except we utilized QR codes, because the other thing we can see in the ODMAP data is that a lot of these overdoses are happening during hours that apartment complex offices are not open. So we felt like we had to get them in the hands of the residents themselves. So we actually left some door hangers with a QR code to DECA's order form, our naloxone program order form, so they could order naloxone for free. And we did see an increase in orders for naloxone from that statewide program. So that's kind of how we got around the apartment issue. We just did a QR code on a door hanger. Some people talked about doing a refrigerator magnet. That way people could always have it, which is probably a better idea than a door hanger, but we were operating pretty quickly at the time. And then I'll talk about cost a little bit. So this is part of what we estimate the cost of overdoses to be, or SUD in general. So you can see our emergency department visits for overdose, right? It's a little over $18 million. If the goal is to reduce that by 20%, potentially cost savings of about 3.6 million. With EMS calls, 20% reduction lead to about 1.6 million cost reduction. But it's the jails that are the primary consumer of dollars when it comes to the SUD population. So just the number of inmates with an SUD costs Kansas statewide in the county jails. This doesn't include the prisons, the statewide prisons or federal prisons. Is about $118 million a year going into the jail system to house or treat people with an SUD. So reducing that by 20% is our biggest cost savings potential, about 23.7 million, which is nearly double of what we have in Kansas for allocation every year under the opioid abatement funds. So really, we're talking about some kind of innovative or systems level changes that allows us to transfer that kind of money into programs that will link people more into treatment, rather than paying for what's probably the most expensive housing program in the United States, and that's our jails. One of the things that I work on particularly is trying to set up overdose fatality review boards in the state of Kansas. I know Kansas City, Missouri recently started one. We've had one in Reno County, Kansas for about 14 months. We've gone through 14 case reviews in that time period. For those that aren't familiar with an overdose fatality review, it's a series of confidential individual death reviews by a multidisciplinary team that works to identify system gaps and make recommendations to cover those gaps. It's also to improve process. Some of you may have suicide review boards. Those exist as well. Some of you may be familiar with like the fatal infant mortality review boards or FEMR. It's based on the same model. Oops. And so here's an example of an OFR timeline. This is completely made up. It's based on some of the things that we would see in an overdose fatality review board meeting, but we label things out. We separate about what kind of call, what kind of data point it is. And then we try to identify some system gaps or things that aren't necessarily working for people. And so for this one, and this does happen quite a bit, we see in our fatality review cases that individuals are constantly booked, arrested for theft. And so we've talked about some kind of pathway. Instead of getting booked, is there a way to link them into a peer navigator or what's called pre-arrest diversion for very low-level crimes? Instead of having to book them, have them go through jail and then get out pretty shortly after, we can link them to a peer navigator and try to get them into treatment instead. Other things that have kind of come up is with our methamphetamine overdose fatalities, we tend to see a lot of cardiovascular issues, so we're trying to work on maybe there's a way to better identify these people. Some of the issues that come up, I think, in overdose fatality review boards is some agencies can be hesitant to change. Right, I think there's a tendency for a lot of us to put the responsibility on the person suffering from the issue. In this case, a person suffering from addiction, rather than looking internally at our own process or our own organizations and putting a responsibility on us. There's some level where we're going to have to meet people halfway, I think, or maybe even all the way, and look more internally rather than at the population we're trying to serve, right? We're going to have to take some of the responsibility on ourselves to improve process. The answer can't just be we asked them a question, they said yes or no. Like, we're going to have to try to build trust somewhere so those answers come more freely. One of the things I've done is I built this overdose fatality review equity tool. So it's got location data for MAT providers. All that's provided by the local community itself. I can bulk import them. You can import them yourself one at a time. Same thing with the harm reduction sites or naloxone distribution sites. You can kind of see Virginia over there on the right. I did a bulk import for them. And so now they have all their naloxone distribution locations on their map. And then the federally qualified health centers, health departments, substance use resources, mental health resources, IHS facilities. There's also some other options to lay the correctional facilities on the map and some social determinants of health data by the census tract level. But the tool does more than that. So you can enter in the person's address. The address is not saved. I'll never see it. No one will ever see it. And then you can pull a radius by miles and then look at who the closest providers are and get kind of a contextual information, particularly if the person doesn't have access to transportation, about how realistic it may have been for the person to access these levels of resources. You can also add transportation to this. So there is an add data option. If your local community has the transportation routes as a geospatial layer, you can add it on here and start looking if they have access to any of the transportation routes as well. And then you can also add walk time or drive time. So how long would it take this person to walk to the nearest resources or drive to the nearest resources? Here's a 10, 15, and 20-minute walk time. So you can kind of see where some of the resources would be in a 15 or 20-minute walk time. We can have conversations about whether or not it's realistic to expect someone to walk 20 minutes. We decided 30 minutes. People tend to lose interest at that point, but 15 minutes was a realistic time. So we tend to pull our data around the 15-minute walk time, which will be this next piece. Or sorry, not the next piece. It's coming up though. The other thing we can do is add the fatalities in bulk. And this was made up to kind of mirror what we see, but this isn't actual patient location data. I just want to point that out. And then we can measure the distance and look at a visual of how close the closest MOUD provider, MAT provider is to those individuals. And so going back to the infographic, this is at a 15-minute walk time. So you can pull an infographic around the individual's area that they live. And for this area, it's 26% below poverty. SNAP utilization rate's even lower than that. So there's probably a food insecurity issue there. There may even be a policy issue, right? Because in Kansas, we have a modified SNAP ban. If you're banned, or if you have more than one drug charge, you're banned for life from SNAP benefits. So part of this could come back into the SUD space. The other thing we can look at is crime index and see, and the way I like to look at this is the types of trauma people may experience in the neighborhood. I honestly prefer to call it a victim index, right? Because usually there's a crime, there's a victim. And so this would also provide information what kinds of trauma and what kind of resources may be needed in a community, particularly if you see that rape, assault, any of those kinds of things are higher. In this case, 100 is the national average. So assault is 230, so it's about 2 times higher than the national average here. We can also look at health insurance rates. So we see a lot of uninsured people in this area. And then we can see a lot of people also struggle with healthcare costs, bilingual population, some rent burden, but not as much as the rest of the county. And then the second page will give you more of the demographic data, civic engagement, internet access, no transportation rates, and then an age pyramid. And what we've been finding is in a lot of our areas with overdoses or fatalities, these tend to be neighborhoods where there is a very high proportion of children or a higher than average proportion of children. And so then we're talking about getting into some secondary prevention resources or recommendations in some of these neighborhoods that tend to experience overdoses or fatal overdoses at a higher rate. The social media use, honestly, I'd like to get rid of this graphic. I don't think anyone uses it. It was recommended as a way to maybe push some communication resources out. I just don't know if it's being effectively used by any organizations that use the tool at this time. I haven't heard anyone use it, but it's there as well, I guess, for now. If people are interested in pushing information, want to see who's using what social media platform more often. And then when you do a cumulative view of it, right, now we can start looking, okay, well, the closest MOUD provider may be about 2 miles away. The health department's the closest. There is naloxone resources within a mile. But within a 15-minute walk time, the only thing was a male residential treatment facility for this person to access resource. So the person was female. Barriers may be even higher in that area for someone suffering with an SUD. So part of the recommendations, I touched on these a little bit. The pre-arrest diversion, improving identification of meth use during cardiovascular visits. Some other ones that have come up is post-overdose outreach. So for instance, we had a case where someone died of an overdose 8 hours after the overdose, and it was 4 overdoses within 1 year. And so the level of missed opportunities there to potentially follow up and engage with this person and offer them resources or at least naloxone, some kind of peer navigation was missed. That brings the other piece of this is actually integrating a peer navigator in a hospital ED. Now this is Hutchinson, Kansas, so that doesn't exist. I know that peer navigators exist in some of our other hospitals, but in a rural county with a little less resources, it may be harder to come by. But we do put that forward as a recommendation. It comes up quite a bit in our meetings. The other piece is family recovery coaches. The reason that this recommendation comes up is we've noticed that in a lot of our cases that we reviewed, they've moved back home, they're with their family, and we're not entirely sure how the family is responding to the individual being in the home or if they're responding appropriately. Because I think there's a tendency to kind of clamp down and shut people off. And that might be the opposite of what that person needs in that moment. And so having a family recovery coach who's been through this with one of their family members or siblings, daughters, etc., having the opportunity to go help other family members with their loved one through recovery, I think would be a beneficial piece. Some states have family recovery coaching certifications. I think Kansas is in the development process of that, but we don't have a certification process for that yet. The other piece was naloxone leave behind comes up as well. Leave behind programs are newly legal in Kansas. They've been legal since last legislative session, so not even a year yet. But equipping the individuals at the location of the overdose with naloxone, whether it's family, friends, whoever's left on scene, gets naloxone closer to where it needs to be, right? There's always a question about how much naloxone we're distributing and whether it's going to the population we need it to go to, or if it's just going to concerned citizens. The naloxone leave behind programs is a very high impact targeted population because they're on scene of an overdose. The likelihood of them being on scene of another one's actually a lot higher than, just your regular concerned citizen. So here's our OFR statuses at the moment. So Reno County started in January of 2024. That's the one we've done 14 of these case reviews so far. We're in the process of doing a full report and recommendations to the governing body about the things that have come up or programs that could potentially work to fill gaps or improve process. Shawnee County's been in discussions about an overdose fatality review. The projected start date was originally July 2025. I'm not sure if we'll get to that projected start date or not. It might get pushed back. And then we've been talking about regional OFRs as well, particularly in counties that share some level of resource. So Allen, Neosho, and Woodson in Southeast Kansas, and then Harvey, McPherson, and Marion County, because they all share the same certified community behavioral health center in Prairie View. So that kind of links those three counties together. These are also all counties that tend to have a lot less fatalities, so it makes sense to share and pull resources to try to make these OFR review boards a little bit more probable. So we do have some data sharing barriers. We don't have legislation that supports data sharing for OFRs. There are legislative examples, and I think LAPA has their own model legislation that states or communities can use to allow for data sharing for the purpose of an overdose fatality review. This includes the sharing of Part 2 data as long as it's stored in a HIPAA certified database. There's a template already in REDCap for overdose fatality review teams. To get around it, we're trying to start next of kin interviews, which I think is a good idea anyway. If you are interested in overdose fatality review, is to do next of kin interviews and get a lot more contextual information from family and friends that knew the individual. But legislation would go a long way to supporting the creation of OFRs, particularly if we could share data. Because right now we just don't know if these individuals were ever in treatment because of the Part 2 limitations. And I just want to point out too, if you are interested in overdose fatality reviews, and I think BJA also does technical assistance for suicide review boards, but there is free technical assistance through BJA and IIR. So I think you can go to ofrtools.org if you're interested in that. There's also a bunch of guiding documents as well. All right, so naloxone distribution tends to be something I'm heavily involved with in the state of Kansas. So part of what I did is measured what would be needed for saturation. And the way that I define saturation here is with very targeted outreach. So if we are in high impact areas, particularly at this zip code level where we see a lot more overdoses, this is the number of naloxone kits we would need, which is a little over 57,000 kits, or about $2.7 million worth of naloxone every single year to reach our saturation levels. You can kind of see where Wichita has a lot more of the top 10 zip codes, right? They have the most need, the most overdoses. But we wanted to flex saturation and model saturation based on the number of overdoses are actually happening in a community, rather than applying a blanket formula across every single county or zip code. Some counties need more than others. Some zip codes need more naloxone than others. So this is a tool that's been publicly made available for all the Kansas communities or naloxone distributing organizations in the state of Kansas. And it's currently getting used as well to try to recruit people into the leave behind program. So in these high burden areas, we can take this information, the costs, the burden, and really try to leverage it to get people to do leave behind. The other thing I'm involved in is helping people decide where to place their naloxone vending machines, right? So these have to be placed in locations that are accessible to the population in need. but they should also involve the participant population in the process. They should be a part of the feedback loop that you get. Not everything can be data-driven, or at least quantitatively data-driven. We do need the participant population to feel comfortable where they're going. So we do try to include them in the process. So I just want to point that out before I show you all this, and it will start to make sense toward the end. So we use locational data as one variable. And so that was what you saw earlier with the heat map. What businesses or facilities are more likely to experience an overdose? So the lodging facilities, gas stations, et cetera. And then we use some of the socioeconomic data, percentage of households living in poverty, no vehicle, and then we use the no high school diploma as well. And then on a 15-minute walk time, with those 4 or those 5 pieces of data, we generate an index. And so you can kind of see the scores and where these place at in downtown Wichita, and then the predominant score for each of those locations. So the number 1 location was CASA, which probably wasn't realistic for an naloxone vending machine. Really, a lot of these at the top weren't realistic as social organizations, but the potential sites are all social organizations because we felt like those were the more probable ones to have a naloxone vending machine or be willing to put a naloxone vending machine in front. It does include government organizations as well. And then in Wichita, there was an interest in including bail bonds. So we did include those facilities in there. You'll see that number 21 is the selected site. So all the way up here near Pine Street, the Second Chance Bail Bonds. And there was a lot of discussion in Wichita about needing 24/7 security for the naloxone vending machine due to vandalism concerns. It wasn't, people in recovery and people who use drugs weren't completely on board with that location, honestly. It was a bit of a mixed bag. Bail bonds do provide services. They're just very specific services. My recommendation was actually to go to number 5, which is Mayflower Clinic and Positive Directions, an FQHC and an HIV testing clinic, because they're in the same building and in the same spot. It felt like it would be potentially more high impact, but there were security concerns around whether or not the naloxone vending machines would be vandalized. So it went to Second Chance Bail Bonds for that reason. They also have a better relationship than the other bail bonds facilities do with people in recovery. And so they were more likely to be trusted among that population, but it wasn't completely on board with the targeted population. So I do want to point that out. The other limit in the analysis was because we were only placing 1 vending machine, we tried to include all of downtown. That included south of Kellogg. But south of Kellogg scored really low, but there is need there. There's a lot of overdoses in that area. It just wasn't as high need as the area that the naloxone vending machine ended up getting placed in. And then we did the same thing in Hutchinson, Kansas. So you can kind of see most of the social organizations, government organizations are all kind of crowded in one area, which worked fine. Once again, with 1 vending machine, it seemed to be where the highest needs were. And then we started having conversations. Well, the health department's ranks number 1 from a quantitative end. You know, are there issues with placing it at the health department compared to the Substance Abuse Center of Kansas, which has residential treatment and standard outpatient treatment? And the answer was, yeah, there were concerns with the Reno County Health Department. So this is when we start to identify other barriers and have conversations with people with experience. Can it be available 24/7? Is the organization trusted, and do people feel comfortable at the proposed site? And the issue really with the health department was the last one. Do people feel comfortable at the proposed site? And the reason being, it's directly behind a courthouse and it's next to the Hutchinson Police Department. And there's constantly sheriff vehicles in the parking lot, right? It may not be as welcoming to people who use drugs to walk up and access naloxone from a vending machine and then walk off. So for that reason, it wasn't placed at Reno County Health Department, had to get placed somewhere else. And then that's where we picked the Substance Abuse Center of Kansas. It was trusted by people who use drugs. It was still in a determined area of need based on the analysis that we were able to pull. And there was also organizational support. So the staff was very supportive of putting the naloxone vending machine at their location. So that's actually all I have. Hopefully I'm still running good on time. There's my LinkedIn if you want to pull me up on there. You can also send me an email. Like I said, I'm happy to connect anyone from Missouri to partners in Missouri. I'm happy to help with any projects on the Missouri side of the border. I collaborate with everyone all over the country, so happy to do any of those things. But yeah, we can go to Q&A if there's any questions.
Now is a great time for questions. We had a couple more statements than questions in our chat. So Brandy said we place ours at gas stations, grocery stores, churches, places where some may be more likely to approach without feeling like they're being watched. And then Trisha said we have a Save a Life station outside our building. It houses naloxone and fentanyl testing strips. It's not locked and has never been vandalized in Topeka.
Yeah, I think the vandalism concerns I think are overplayed. I hear vandalism stories nationally, but they're not the bulk of what vending machines come out. So, like I said, in my opinion, I think if you were concerned about vandalism, there's still, you can take other routes. They don't need to be at a place where someone's operating 24/7. I think you can use cameras or whatever else to try to deter people from vandalism. But I still think the threat of vandalism on the vending machines are probably overstated.
And then Brandy also stated that naloxone stations, we have 6 almost ready to distribute in KCMO and several in Topeka and Manhattan, Kansas.
Yes. Yeah, I did not know that.
And then Tiffany just said our probation office in Lenexa has a naloxone dispenser in the lobby, and it's unfortunate we can't keep it stocked.
Yeah, and that's a good point too, because I do want to point out that both of those vending machines in Wichita and Hutchinson, the first 2 months particularly, they were very, very difficult to keep stock. I think the Wichita one was at 600 kits a month for the first 2 months, and now it's kind of calmed down to 200. But even 200 kits a month, you're still having to stock it quite a bit, especially because there may be fentanyl test strips or other resources. But yeah, it's a good thing to keep in mind if you are thinking, I'm interested in having an naloxone vending machine in my community or at my facility. Those first couple of months will be crazy because everyone's going to want to get it. And the chances are, that 400 excess overdose kits are probably the people that need it less. They're just the concerned, community citizen would like to carry it. And then that other 200 a month is probably the people that actually need it and will potentially use it down the line.
What other questions do you guys have? I know a couple of people have asked for the PowerPoint. We no longer put our PowerPoints on the Metro Council site. But if anybody, DJ, would it be okay if they contacted you?
Yeah,
Okay.
yeah, that's fine.
So if you're interested in that, you can contact DJ. But unfortunately, we cannot put ours on our site anymore. So okay. Oh, good question. Emily asked, do you know of any naloxone distribution places that mail out naloxone to people?
Yeah, so I would say the bulk of distribution in Kansas is happening through the mail. Through DECA, that's our statewide program. If I remember right, it's about $1 million in naloxone. That's primarily mailed out. So a lot of what's happening on the vending machines pieces, particularly I think with the Save a Life stations in Topeka, those are funded out of pocket or funded by local organizations and not funded through our statewide naloxone program, at least not fully. Statewide program may be contributing some level of naloxone to those, but it's being primarily funded, I think, at the local level. Now, there are benefits to that. In my opinion, it's also really hard to track about, who is it going to. So we often find that some of the mail order programs are coming from law enforcement, very specific officers, potentially their agencies don't have agency-wide naloxone or don't have a policy on carrying naloxone yet, so they've ordered it themselves. And then we also can't track if it's getting to where it needs to go the most, I would say. So there's some, I think, implementation and evaluation standards that are probably missed through the mail order program compared to probably like the on-the-ground distribution program where you're actually face-to-face interacting with people. It's a little easier to know how well your distribution is going, if it's going to people who need it most, et cetera.
Okay, another question. I know context clues are harder to come by with quantitative data, like you said, but is there any awareness about how prevalent fentanyl poisonings are among people unaware that they are taking it? I see so many articles about teens passing away because they thought they were taking Xanax or something, but it was cut or pressed with fentanyl, for example.
Yeah, and that's a good question. And a little bit more difficult to answer, I think. So what I will say is Kansas has the highest youth overdose fatality rate, unintentional overdose fatality rate in the entire country. Now, just saying that is a lot, but when you actually look at the number of fatalities compared to, I think, what is about 650 fatalities in the state of Kansas, it only makes up about 20 of those. So having 20 to 22 youth fatalities in the state of Kansas has been enough as a proportion of population. The youth population makes us the worst in the country. The bulk of fatalities are happening in that 25 to 44 age range. In the 25 to 44 age range, all know they're using fentanyl. That's the drug of choice for most people. I do still think on the youth end that those 20 fatalities are primarily driven by people that likely didn't know or weren't informed about counterfeit pills with fentanyl, or felt like maybe we're just overhyping the issue and didn't really believe the messaging that we're putting out. So really, like, whether or not the message is actually communicating well is a completely different question. There's really no data or information about how well that message is getting across to youth specifically. And then kind of like what I was going back to earlier, I'm not entirely sure if the cocaine use is known for adulterants of fentanyl, because that's also got xylazine and fentanyl mixed in. And so when we look at xylazine and fentanyl fatalities, where both of those things exist, the most common third substance is actually cocaine. So I think we're missing a big gap on education for people who use cocaine. Naloxone policy for law enforcement officers. I don't have any specific policies that come to head. I could probably get my hands on some examples of ones that law enforcement agencies have passed to cover themselves. For the most part, though, it's been more of a non-issue since the naloxone that law enforcement agencies are primarily using are the OTC ones. Prior to that, a lot of people felt like they needed a policy due to it not being available over the counter. But I think there's been a little bit of a shift there, but I just don't know how much. Yeah, there is a naloxone bill specifically for law enforcement. And the last time in Kansas that I think I saw it was almost 4 million for 1 year, which in my opinion is probably 3.5 million more than what law enforcement would potentially need. Unless they're measuring it based on some other standard, like this is the number of kits we need for every single officer in the state of Kansas, and potentially it gets up to that $4 million number. But as far as use goes, That is a really high number, and I hope that if there were excess naloxone from that bill, there would be a way to work with the local community organizations to distribute it.
Okay, so any other questions? Okay, with that, I'm going to put up the certificate of attendance. All you need to do is click on the link and put in the password. You'll be able to get the certificate. So with that, I want to thank all of you for attending today. I want to thank DJ so very, very much for presenting. It was very interesting and informative to really hear about uh, all that's going on around opioid and fentanyl overdose and overdose prevention. And I found the little icebreaker hilarious. So with cows to people. So thank you so much. And if you guys have any other questions, we'll stick around for a couple minutes. Otherwise, thank you all and have a great day.